Yeah, thank you very much for the introduction. I'm actually also very pleased for Charlie Swanton's talk already, because it paves the ground for my 5 cents of wisdom. I'm a clinician. I treat these tumors or the patients with the primary tumor in place, and I'm especially intrigued by it, and I think that a lot of the findings that Charlie talked about in his presentation are actually reflecting what we see in the clinic. These are my disclosures. Of course, we need to briefly touch on Surtime and Camina, both trials that finished recently. I think what is very, very important is that both trials try to answer a different question. Surtime, the role of cytoreductive nephrectomy based on the old SWOG design that was used in the 1990s and reported in 2001. And Surtime actually looked at the sequence with the idea that pre-treatment might identify those patients who are not benefiting from surgery. But look at that, I mean, the whole design thing was different. Camina was a non-inferiority study looking for OS Surtime superiority, a 30% improvement of PFS. That was necessary because at the time we calculated it, it was considered that we would need 780 patients to prove overall survival difference. Eligibility was different. Camina just looked at ECO 0-1. We used surgical risk factors, which had never been validated but published by CULP. There was a difference in MSKCC poor risk inclusion here, and most importantly, although both studies failed to include their aimed number, Camina was much more powerful with 450 patients included, and Surtime only 199. So by all means, Surtime was, because PFS didn't deliver a negative trial, but we found a signal which was quite staggering in terms of a 17.4 month survival difference, which even remained to a certain extent in the per protocol population in the deferred arm, and that included the patients who did not proceed to nephrectomy, which was about 30% in this trial. Then Camina came along, which was reported a year later at ASCO in 2018 and simultaneously published in New England Journal, that showed no difference in terms of overall survival between upfront nephrectomy followed by sunitinib versus sunitinib alone. But mind you, and that is very, very important, there was an option to perform secondary cytoreductive nephrectomy. And I'm always very intrigued with that, and this is a sort of construed slide here because I don't know the actual figures, and I'm sure that the Camina team will actually look at that, but you may take a different perspective on it. We know that 40 patients in the 2019 update underwent secondary nephrectomy in the no-nephrectomy arm. That is 18% of the sunitinib alone arm. Now, this is really not a lot and does not lead anywhere, but when the trial was designed, I think most of us would have thought, well, they end up with a couple of problems because of local bleedings, local symptoms, and these tumors have to be removed. But no, that wasn't the case. 33 of these patients, so really the majority, had a secondary nephrectomy because of complete to near complete response at metastatic sites. And they started to do that at 7 months into the trial. Now, this is a bit hypothetical here, but let's assume, because poor risk patients, we know they do behave very poorly. If we exclude the 41% poor risk in the sunitinib-only arm, we are really dealing with 131 intermediate risk patients here, and roughly 100 of them are alive at 6 months. So in other words, you might take this different view that if you live long enough as a patient and you do well, you probably are being offered a secondary nephrectomy in 1/3 of the cases here from this calculation. The other thing which I find quite striking is there was the post hoc analysis of the IMDC risk factors in Camina, which was presented at ASCO 2019. And again, look at this here, IMDC 2 risk factors, which is matching the Surtime cohort. Not large figures, I agree, post hoc, so let's be careful. But we see almost the identical massive survival difference here that was seen in Surtime. And this includes an unknown number of secondary nephrectomies. Again, we would have to ask the Camina team here, how many of these 76 patients had a secondary nephrectomy? So this led us to, in both guidelines, ESMO and EAU, to actually come up with this recommendation that patients who require systemic therapy, and that is very, very important, if they require systemic therapy, they should not be offered an upfront cytoreductive nephrectomy, but they should have this option if they have a very good cause of the disease, and certainly if they develop problems. And I think it is very, very important not to take this as orthodoxy here. I mean, IMDC factors or MSKCC factors, you may be wrong in 30% of the cases. And I've been to meetings where cases have been presented of patients who were poor risk, then desired to have a cytoreductive nephrectomy, and then they improved completely. And they were poor risk largely because of their performance score. So I think you really have to look careful at the patient. Is there a difference, for example, in the volume of metastatic disease? Is cytoreductive nephrectomy cytoreductive at all, for example? Where are the metastatic sites? It takes a bit more than just this sort of orthodoxy here. But what now? I mean, first-line therapy is changing. All these studies were done for sunitinib. What should we do now? I mean, the knee-jerk reflex is to say we need another trial. This is a very interesting concept. This is a trial they want to do with a SWOG in the United States. Interestingly, they seem to already have acknowledged that upfront therapy is not what you should do in this patient population, because they're randomizing to an arm which resembles Surtime's arm, but then with Ipi/Nivo, and then the arm of Camina, which was, well, systemic therapy only with the option to do a nephrectomy. But I want to take a bit of a provocative view here. I mean, you don't hear me saying we shouldn't do these trials, but I think you really have to be careful, because we know that these trials are difficult to perform. I like to call them paleo trials, because they're big as dinosaurs, they're prehistoric. We will need another 8 years to report. The idea is nice, but systemic therapy standards are very likely to change 3 times over in this period. Every single cytoreductive nephrectomy up to now has taken 8 years to complete. The patient population is decreasing, which is very good news. We see that in the United States, and we're down at 18%, in Scandinavia 10%, so not the 33% of primary metastatic patients anymore. But I think most importantly, it's already what Professor Swanton alluded to, is the heterogeneity of the disease. And I'm very grateful to his talk, and these are actually 2 cases from our clinic here. So we all know these patients where you have a large primary and oligometastatic disease. You can either treat it focally and bring the patient in complete remission, and then on the other spectrum, you have these patients who have multiple metastatic sites, and the whole idea of doing cytoreductive nephrectomy here defeats the whole process, because the tumor is small and the metastatic volume which is left behind is much greater. And I'm absolutely convinced, although this has not been validated, that this is exactly matching what we're seeing in the clinic. And we're also seeing these patients here, and this is always a multidisciplinary team discussion. These are 40 patients from the NKI at Amsterdam, where we would normally ask our medical oncologists, do you have a reason to start systemic therapy once we've taken the kidney out? And if the question to this is no, and the patient is in a very good condition, we perform cytoreductive nephrectomy. And that was a bit based on the prospective trial that Brian Reaney did, and which was published in Lancet Oncology, on observation. And I'm sure you can do that. Again, here we saw the same phenomenon. The median time to progression was rather short, but not every single lung nodule that increases needs immediate systemic therapy. So the median time to targeted therapy at that time was 16 months, which I think is very, very interesting. But what for all the other patients who need systemic therapy? I'm absolutely convinced that Surtime and Camina leave a legacy behind, and in my point of view, this legacy is, and that's my opinion, it's completely unfounded, there's no science behind it, but we will see more and more patients who are now being treated with the primary tumor in place. This has been done in a couple of studies. We will see a poster tomorrow on the Javelin. It has been reported in Checkmate 214. So these patients are safe to be treated. If they need something to control the disease, I still believe it's better to do that. But I'm absolutely sure that we will see a couple of these patients coming along who will then require deferred cytoreductive nephrectomy. And it's very, very likely to happen in this group, which has a complete response at metastatic sites, which has been reported in up to 11% in Checkmate. But we will also see this, I think, in the group of patients who have a clinical benefit and are then stable for a couple of years. And then this question comes up, listen, shall we remove it or not? What shall we do? And this is an example of a patient we saw in London recently. I can't disclose which combination this was because the patient is in an international trial, but there's a complete response at metastatic sites. Look at the decrease here. But what we also found, and when we did the surgery, that was removed robotically, but it was quite stressful because the the fascia of Garota was inflammatory thickened. We also see that in one of our neoadjuvant trials we are currently performing, and it's more likened to, for example, performing RP-LND after chemotherapy for seminoma. So I think this will also need different surgical skills of those colleagues who are treating these patients in the future. But this, I think, is already something that we're seeing now and which is currently happening. So I think rather than doing these big trials, we should actually start having registries, prospective registries. We could do that across Europe or worldwide if we want. We can also think in multi-arm platform trials, small trials which are powered for safety and efficacy, where you then change your concept. But this would all allow us to assess the, for example, metastatic phenotype that has been reported, validate this, for example, look at whole gene sequencing, transcriptomics, the whole thing that Tony Chiueri so nicely summarized yesterday in his talk. So our brothers in melanoma are at this stage at the moment, and admittedly they have a larger variety of how they can treat patients, but they sequence them before, give them the therapy they should receive, then in case of relapse, resequence them, and then give them something else. And I think that is the way we should all go forward, and we will have the armamentarium here. We've all seen these slides. It was also in yesterday's educational session. But if you look at the differences, you can already see, for example, with patients who have an angiogenesis-driven profile, these are big differences in small numbers. So if you would do crossover studies here, for example, you wouldn't need these big patient numbers as we've seen in the past. And rather than summing up everything, I would like to draw your attention to tomorrow's poster discussion, which will discuss 2 posters where patients have been treated with the primary in place, and one of them actually has a full genomic workup here. Thank you very much for your attention, and ready to take